Good afternoon, everyone. It's Ken Murphy from GP Connections. Just like to hand over to Dr Jeff Prebble to get it going. Just a reminder to anyone, the bottom left-hand screen, you're able to click in there and type in some questions. So at any stage, I'll hand it over to Jeff now. Thank you.
Thanks, Ken. I hope you can hear me all right. The title of this presentation is Learning and Behaviour Problems, and this is really to present as an overview because I think this is what we are all seeing lots of. To set the scene, I'd like to present two cases, and they're just typical cases of the sort of children that we all see, but hopefully it'll set the scene as to an approach to them. The first case is a early school-aged child of 6 years, brought in by his mother with concerns regarding his poor school progress. Comment was made that he was overactive, also that he was disobedient, and that he was an aggressive child, and that there were temper tantrums. When one went into the further history, although his previous health was unremarkable, there were some significant factors in the family, and as I'm sure you all appreciate, there are a lot of family issues these days, and in this case the parents had been separated. There was a history of domestic violence. Mother had suffered from depression, and her new de facto took a fairly authoritarian approach to discipline. And physical examination, as is usually the case, didn't reveal any specific abnormality. And so obviously with that sort of a case, the first question that we all have to consider is, well, what's the problem here? And the second question is, what are the specific diagnoses? And clearly in this case, one of the considerations is, has this child got attention deficit disorder? Has he got a specific learning impairment? Or is this all the sequelae of the dysfunctional family? Once a diagnosis has been made, then one can approach management. The second case is a 7-year-old girl on this occasion, brought in again with failure at school, and again associated behaviour problems, of defiant behaviour, and notably few friends. The past history was unremarkable. The family history likewise was unremarkable. Both parents were healthy and well, happy marriage, but both were very busy professional people, very involved with their own careers. And clinical examination of the child revealed no abnormality. And again here, the assessment needs to be looking at, well, what are the learning capabilities of this child, looking further at the social aspect of the child, and then coming up with a diagnosis. And the sort of things that one would consider is, has this child got a form of autistic spectrum disorder? Has the child got a learning impairment? Is the child suffering from some emotional problems? Is the child being bullied at school? And clearly, until we know what the particular diagnosis is, then we can't undertake appropriate management. So my friends, looking at learning and behaviour problems, I guess the first thing to say is that it's common. It is estimated that between 10 and 20% of children do suffer from either learning or behavioural problems. And certainly it is referred to as the new paediatric morbidity. And it is true that if this was an infection of some sort, it would attract a lot of attention from health authorities and the media. The reality is that in some ways it's sort of hidden. It's not as obvious, and it doesn't get the research funding that perhaps it deserves. It is considered the commonest outpatient problem seen by paediatricians, and I think most of us would attest to that. A review of the United States indicated that there 5 to 26% of children will suffer from behavioural problems. There was a study done in Australia in 2000, and it looked at the mental health of young people, and again it just indicated the high incidence of these problems. The study showed that about 14% of children aged between 4 and 17 years of age experienced some mental health problems in the preceding 6 months prior to that survey. And in the preceding 12 months, there was an incidence of depression just under 4%, conduct disorder 3%, and attention deficit hyperactive disorder a little over 10%. So clearly these are common problems, and when this study looked at what services we use to help children, school counsellors, general practitioners and paediatricians were the commonest professionals involved. The first thing to consider, I guess, is what is the etiology, what's the cause of these problems? And I regret to say that I don't have a simple answer. For a long time there's been the debate over whether it was nature or whether it was nurture. Was it the way the child was at birth? Was it a genetic predisposition to this particular behavioural difficulties? Or was it the combination of postnatal and early childhood experiences and the environment that the child grew up in that was the result? And I guess our conclusion is that it's probably a combination of both of those. It's not just one. When we look at learning problems, children who present to us with difficulty learning, then I would suggest that there are 4 interplaying factors that would contribute. Developmental problems, medical health problems, behavioural problems, and environmental problems. And each of these will contribute to the end result, which may be difficulties learning at school and behavioural difficulties as well. To expand on that, if we look at the developmental issues, clearly some children have a variety of difficulties in their development. In the most severe instances, it may be that the child has intellectual impairment, and obviously children with intellectual impairment cannot be expected to function normally at school. And only this morning I saw a child who's in grade 7 at school. A psychometric test 2 years ago showed that the child has an IQ of 65, and the parents still were concerned as to why this child wasn't doing well at school. And clearly this child is intellectually impaired, is in a normal class environment, and is now developing frustrations, low self-esteem and anger behaviour. Apart from intellectual impairment, some children just have some specific learning problems or some deficiencies in their cognitive function, and that may manifest with dyslexia or just some specific areas of learning impairment. There was an old terminology, minimal cerebral dysfunction, which seems to have disappeared today, but it was a reference to children who just had some minor neurodevelopmental difficulties. As we all know, environmental factors can impact on the child's development, and such things as exposure to abuse, domestic violence, dysfunctional families, or parental psychological problems. And sadly, so many of the children that we see today grow up in this sort of environment. Again, we see children where the mother has been had a drug problem during the pregnancy. The child may have suffered narcotic withdrawal syndrome. The child grows up in an environment where parents are fighting. There may be verbal abuse, there may be physical abuse, and all of this has an impact on the developing child. It is said that the first 2 years of a child's life is the most important time in developing the basic psychological development of the child. And so it is thought that what happens in that first 2 years has an impact for the rest of life. And sadly, we see so many children who are adversely affected by this domestic environment in that early period of time. If we now look at the individual behaviours of the child, and there are some specific behavioural disorders, attention deficit disorder or attention deficit hyperactive disorder, I think is a real condition. There is a lot of debate and controversy, particularly driven by the media, but this is not a new condition. It's been described for over 50 years, and Ritalin medication has been used for that duration, and so it's been well researched and well established. One of the problems is, however, that there is no objective test for behavioural disorders. It is a subjective assessment based on the parent's observation, the parent's description, and also on the teachers or the kindergarten teachers' observations as well. The clues to attention deficit disorder obviously is that the child is inattentive in situations where you'd expect the child to be able to concentrate quite normally. The child usually also is impulsive, so they act without thinking. They're easily distracted, more easily distracted than other children. And some of the children are very active, hyperkinetic behaviours, but not all. And certainly one needs to recognise that there is an attention deficit disorder without hyperactivity, so it's not an essential requirement. I think we have to respect that school teachers are probably in the best position to provide assessments of attention deficit disorder because they have the rest of the class that they can compare this child with, and hopefully that will give us a more objective assessment of this child's attention abilities. The second behavioural condition to consider is oppositional defiant behaviour disorder. And some would maintain this is not a diagnosis but just a description, but certainly we see lots of children who are defiant and oppositional. And I'm not really sure whether this is the way the child is or whether it's a reflection of inappropriate behaviour management, and perhaps it's a bit of both. The condition that really now attracts a lot of interest is autism spectrum disorder. When I was a medical student, which was in the 1960s, the incidence of autism was 1 in 10,000. 1 in 10,000. Today, autism spectrum disorder is said to have an incidence of 4 to 5 per 100. There's been a dramatic increase in the incidence. Now, I'm not sure why this is, and I don't know that any researcher is able to answer the question. It is true that we have a broader definition of the condition. So with the advent of Asperger's syndrome in the 70s, late 70s, that has broadened the definition of autism spectrum disorder. And so maybe that's been a factor, and I'm sure it has. But I think there is a real increase in the incidence of autism spectrum disorder, and I don't understand why. There was a recent review article in the Medical Journal of Australia, and the epidemiologist basically said that they couldn't provide an explanation as to why there has been such an increase. They've looked at genetic factors, but have been unable to find any consistent chromosomal or gene abnormality in these children. And they've looked at environmental factors and have been unable to provide any explanation of any specific change in whether it be food or preservatives or anything else in our environment that might be a causation. One of the things about autism spectrum disorder is that it is a very broad condition. The manifestations vary from child to child, and the prognosis varies from child to child. Although the overarching symptomatology is one of poor socialisation, speech and language problems, concrete thinking, and some obsessional behaviours, the manifestations do vary enormously. And this recent review article suggests that maybe in the years to come, autism spectrum disorder will be found to be a combination of perhaps 10 or 20 or more different specific disorders. The reality is that it is common. We see a lot of it. Rightly or wrongly, it does attract additional funding in the schools, and so understandably schools are very keen to receive a diagnosis of autism spectrum disorder so that the school can use this funding to assist the child. We do recognise, and in fact there have been publications to confirm that the diagnosis has been given to children who probably don't really have the condition, but rather to ensure that they receive extra support and assistance at school. In the severe autistic child, there is no doubt that we try to make a diagnosis by 4 years of age. With the Helping Children with Autism package, there is considerable opportunities and funding for assistance in that 4 to 6 years age group, and so that's clearly our aim, is to try to make that diagnosis by 4 so that the parents can access that funding of $6,000 for $6,000 per year for 2 years. In addition to ASD, we do see an increasing number of children who suffer from anxiety and also from depression. And again, the sense is that the incidence of these is increasing every year. Other behavioural problems, obsessive compulsive disorder. When I was a young paediatrician, this was never seen in paediatric practice. It was said to be a problem essentially of adults, but clearly today children are presenting with OCD. And this can be a very debilitating and serious problem for children, and really does affect them and of course their family as well. The motivation deficit disorder, I have to apologise to you because that's a make-up disorder that I've invented, and so I'm sure there'll be many of you who disagree with me. But from time to time I'll see children where perhaps the consideration is that they've got attention deficit disorder, but on my assessment, rightly or wrongly, the problem is that the child can concentrate very capably on activities that the child enjoys doing. So it might be television, watching DVDs, reading a book, Legos, playing games. But when it comes to activities that the child doesn't particularly enjoy, such as schoolwork, the child is incapable of concentrating. To my mind, attention deficit disorder means that there is a lack of concentration and application in all situations. Whereas the child who is very selective, and it's the thing that the child doesn't particularly find enjoyable, then to me that's more a motivation and application rather than ADHD. I think if we think about it, we remember kids that we went through school with who in school just didn't cope. They didn't study, they didn't learn, and yet later on after they left school as young adults, they then went back and did mature study and achieved very well. And to me they were kids and then adults who suffered from motivation deficit disorder. Anyway, that's my little hobby horse, and I apologise for including it. Bipolar disorder is another behavioural psychiatric disorder that when I started in paediatric practice was described only in adults, but increasingly there are reports in children, and obviously that's a concern. And then conduct disorder is really the most extreme form of behavioural problems, where the child really is essentially out of control and is doing quite inappropriate antisocial activities. And sadly, these are the sort of children who will in the future, or may in the future, attract the court system. So the real question is, well, what can we as doctors do to assist these children? I recognise that I'm not a psychiatrist, I'm not a psychologist, and yet I'm regularly asked to see these children. And so I say to myself, well, what is it that I can do to help these children? And I would like to suggest that for all of us, there are 5 things that we can offer to these children. The first is an assessment of what are the problems, what are the issues with this child and with this family. The second is to look for any specific underlying cause. The third is to consider what management is appropriate for this child. The fourth is to then talk to the parents about what can be done and to try to explain to them the condition of the child and the management that we would recommend. And then finally, the need for ongoing support and review. The reality is that with all learning and behaviour problems, there is no quick fix. This is a long-term, ongoing plan of support and care And so I think the role of general practitioners is crucial in providing support for these families over the years that these children have their problems. If we look at those in a little bit more detail, first of all, the assessment of the problem. My suggestion is that we need to look first of all at what is the child's intellectual capability. Is the child failing at school because they just don't have the cognitive ability? Or is the child failing at school because the child's got the ability but just doesn't apply it? It may be that the child's behaviour problem is not due to environmental factors, but rather that the child isn't coping at school, has low self-esteem, and is becoming frustrated. The second area is to look at the medical health of the child. And obviously, a child who has any chronic medical problems will be handicapped with regards to their learning processes, and also may be handicapped with regards to their psychological and emotional development. And so I think we obviously need to make sure that there is no underlying health issue that needs to be addressed. One of the areas that, or one of the chronic medical problems that I think impacts on behaviour is type 1 diabetes. My experience is that a lot of our diabetic kids do develop emotional and psychological problems which can impact not only on their behaviour but also on their learning and their school progress. And I've often wondered why that was so, because other conditions, say cystic fibrosis, epilepsy, the children there don't seem to be as significantly affected. And recently there was a study that suggested that maybe the the elevated blood glucose can have an effect on the brain and may, as a consequence, affect behaviour and psychological development. It's an interesting thought, and certainly would fit in with my observation that so many of these kids can, during adolescence, seem to really become quite rebellious. Of course, one does accept that the management of diabetes with daily insulin injections and blood sugar taking is pretty difficult. The environmental factors obviously need to be assessed, and that often I have to rely on what the parents tell me. Often referral letters don't include very much about the environmental factors. And to make it more complicated, often parents won't tell me about what happens. And it may be several visits before the whole story or part of the story comes out. And then finally, in the assessment of the problem, we need to look at the behaviour of the child and consider, what particular behaviour problems the child is having. Is this an attentional problem in the sense of ADHD? Is this a problem of socialisation, suggestive of autistic spectrum disorder? Is this depression, etc., etc.? The second role that we as doctors have is to look for a cause, and in looking for a cause, the reality is that in most of the children we see there is no specific underlying disorder within the child. But clearly it's important for us to do a neurological examination to exclude a central nervous system disorder. It's also important to consider the genetics, particularly in autism spectrum disorder, where genetics seem to play a role, and often we see 2 or 3 children in the one family with autism spectrum disorder. As you would be aware, the screening genetic test recommended today is a CGH microarray. Formerly we would do just a chromosome test, but a CGH microarray is a more detailed genetic test and is now has surpassed chromosome assay as the standard genetic screen to be performed. It's also important to consider hypothyroidism. Clearly children who have learning problems or depression may well be hypothyroid. And so the clue to hypothyroidism is not only some delays in intellectual development, but also short stature. Just recently I saw a child with attention who had been treated for 2 years for attention deficit disorder, and but I was just asked for a second opinion. And although the child actually had no clinical features, I just did a thyroid function test, and to my surprise, the child in fact was hyperthyroid. He was thyrotoxic. And so once that was treated, the attention deficit problems settled quite quickly. Now that's a rare cause, but it certainly indicates the value of thinking about thyroid function testing. Again, epilepsy is a rare cause. Landau-Kleffner is where there is a epileptic condition associated with a deterioration in speech development. And so the presentation may not be with specific convulsions, but rather with a deterioration or regression in speech development. And EEG may well be helpful in making that diagnosis. The third area of our role as doctors is to offer some specific management plan for the children. And I would divide that treatment into perhaps 4 areas. One is medical care. The second is educational care. The third is psychological care, and the last one is developmental care. If we look at medical care, obviously it's our role to ensure that the child's physical health is as good as can possibly be, and as part of that to ensure that the child's dietary care is appropriate and their nutrition is fine. Rightly or wrongly, a lot of school teachers tell me that they identify that a lot of children with attention deficit hyperactive disorder in fact have a very poor diet, and they look at the school lunch that the children have, and they often claim, and I believe what they tell me, that there is an association between very processed foods and inattention in children. If we make a diagnosis of attention deficit hyperactive disorder, then we may offer the children medication, and as you know, the standard medication is methylphenidate, Ritalin, and that may be in the short-acting form, the 10 milligram tablet, or it may be in the long-acting form, the Ritalin LA or Concerta. In other psychological disorders such as depression or anxiety, there are psychotropic medications that can be used. And in autism spectrum disorder, there are medications that can be used. Particularly risperidone is valuable for the children who have a lot of anger or aggression, and some of the antidepressants can be useful for children who have a lot of obsessional traits in autism spectrum disorder. The use of psychotropic medications in children is something that I must say worries me. I, like paediatricians in general, do prescribe these medications, but one is always somewhat fearful of what's the long-term consequences of these medications. I think that Ritalin has been around for long enough, and the studies have been done, that I feel content that it, in the long term, is a safe medication. But we have still to learn about other medications such as risperidone or antidepressants, just what the long-term consequences are. The other medication that we do use is, as you know, is melatonin. Melatonin has been used to help with sleep, and its big advantage is that it is a natural product, a natural hormone from our body, and it seems to not have any adverse effects. It seems to be well tolerated, it's not addictive, and it's not sedating. And so I think melatonin has a role in children, particularly in autism spectrum disorder. It seems to be helpful because many of those children do have sleep difficulties. Looking at the educational management, our role there is not really to interfere with the role of school teachers, but really just to provide an appropriate diagnosis so that the school can provide appropriate curriculum and appropriate supportive care for the child at school. If we look at the psychological side, certainly in my working career I've seen the increased numbers of psychologists, an enormous rise in psychologists, and so many children now need counselling and CBT and behaviour management and anger management, etc. Our allied health colleagues can provide developmental support for children, and that may involve occupational therapy to help with handwriting. It might mean speech therapy to help with speech, language and literacy. It may involve a dietitian to help with appropriate dietary care. Parental counselling is the next one, and I think our role here is to try to explain the diagnosis to the parents, provide them with a plan of management, to give them some idea of an expectation of the future, but honestly indicating that clearly we don't have a crystal ball, and in many circumstances we can't give an accurate prediction, but we try our best. In most of these conditions there are now support groups that will be useful for families to obtain help and encouragement. We need to recognise that many conditions do have genetic implications, and so genetic advice to the families is also important. And then finally, to consider respite care. I think respite care, there are a limited number of respite centres, but certainly involving extended members of the family to try to provide help for parents is a very important thing. And so often parents feel that they've got to, particularly mothers, feel that they've got to labour on and do the very best no matter what. And clearly in the long term we need both parents to be involved, and we need both parents to remain reasonably fit and healthy, so that they do need a break and a respite at times. And then finally, the need for ongoing support and review. I don't have the answers to everything, but a couple of things that I've learned along the way and people have told me. I think the first is that we need to respect that parents in general try to do the best they can. That may be limited by their knowledge and experience, but it clearly is not appropriate to criticise parents. It's important that even if we think the parent is absolutely hopeless, that we've still got to try to provide them with encouragement and ongoing support. It is true that if we can provide that engagement and identification with the parent's ongoing struggle, I think that gives them some relief, and it also gives them some faith in us as practitioners. We need to provide understanding, we need to provide encouragement, and we need to provide a ready sympathy for the difficulties that they're encountering. One of the difficulties is that we need to look at both parents' point of view. And this is, even in couples that are together, this can be difficult because sometimes a mother and a father will have differing views on what the problem is, and even if there is a problem, let alone what management or treatment is offered. And so this problem is even worse if parents are separated. And there you may well have conflict between parents, open warfare, and the child sometimes is used as a bit of an instrument in that warfare. It is really important for us to try to listen to both sides and to try to come up with a plan that is acceptable to both parents. And this is not always possible, but certainly if we don't do that, I think we often end up with a situation where we make the conflict between parents even worse than it was before. Sadly, with learning and behaviour problems, none of us have a cure. And I think our focus is to try to help families to cope with this difficulty rather than to expect that we're going to cure the problem. In conclusion, can I just make or just give some advice as to what I find very useful and I appreciate in referral information when children with learning and behaviour problems are referred to us. Obviously the past history is really useful. What medical problems the child had in the past, what endeavours have been tried with or without success in the past. One also looks at the family history, and any information that you can provide regarding the family history is certainly sincerely appreciated. The domestic circumstances are really, if there's anything there that you're aware of, you as general practitioners will know that much better than I will. And recognising that often parents aren't honest and don't want to tell us about the difficulties that are going on. And so that if you are aware of significant factors in the domestic arrangements, then it is really useful information to receive. In assessing these children, it's not just a matter of talking with the parents. One always likes to get information from schools, particularly school teachers, as to their observations. If the child's been assessed by a guidance officer, and particularly if the child's had psychometric testing, then that information is really vital. If the child has previously been seen by other therapists or psychologists or medical colleagues, then clearly that's important to have that information. If the child's had investigations in the past, then of course that information is most appreciated as well. The other thing in the referral information I do appreciate is if you can tell me what it is that you want. Is it a diagnosis? Is it a plan of management? Often that's something that I don't understand from the referral letter, and I have to ask the parents then what it is specifically that they're looking for. So it's very helpful if you are able to advise me of that. Finally, I would say that if it's possible, I certainly appreciate receiving reports, etc., before the actual consultation. It gives me time before that consultation to sit down and read through it. I mean, often reports will be many pages, and that can take up the consultation time. So it's much better that I do that at some other opportune time and have all that information ready before I actually see the family. So my colleagues and friends, what I've tried to do this afternoon is just to provide an overview of childhood learning and behavioural problems, looking first of all at the incidence and the fact that it is an increasingly common situation, recognising that the etiology is multifactorial, but that in our medical role we need to assess all of those areas, try and find an underlying medical cause, and then try to provide a plan of management and ongoing support and care for the family. And that's all. Thank you very much, and I'd be happy to answer any questions.
Thanks, Jeff. It's Ken Murphy from GP Connections again. Just a reminder to anyone, if they want to type some questions in the bottom of the left-hand screen. There was a question earlier in regard to the incidence of autism, whether it was potentially related to antenatal or television. Perhaps if there's been any thoughts on that one, Jeff?
Thanks, Ken. I don't know the answer to that. Certainly, antenatal ultrasound has attracted research concerned about the potential hazards of ultrasound, and while I'm not really fully aware of the details, my understanding was that no adverse effects was identified. But it's a very good point that's made, whether or not it's related, but certainly the dramatic increase in autism spectrum disorder does seem to correlate with the increased use of ultrasound. Again, when I talked about when I was a medical student and it was a rare condition, that was when ultrasound was first being introduced. And now, of course, it's used extensively, and most pregnancies would have a couple of ultrasounds, if not multiple. So I don't know the answer, but it's an interesting concept. I'm not aware of any association. The other question was television. Television's been around for a while. I don't know that television, I don't think there's any evidence that television is implicated in autism spectrum disorder, but certainly there is very good evidence about the association of television and behaviour problems, particularly aggression and oppositional defiant behaviour problems. So that, yes, I think television is has a very potent effect on child behaviour.
Thanks, Jeff. Did anyone else have any questions or comments for Jeff, or has he once again astounded us all with his knowledge and answered all of our questions? On the bottom left-hand screen, when we refer to learning difficulty problems, kids, do you want us to do a baseline blood test prior?
Yeah, thanks, Ken. I think the answer to that is, in general, no, unless you thought that there was some specific medical issue, but the answer is no, not as a routine.
Once again, Jeff, on behalf of everyone and GP Connections, thank you very much for your time. It's very much appreciated. And if anyone does have any questions that they do want to ask and think about it afterwards, if they send it through to us, and we'll certainly pass it on to Jeff and try and get some results for you. Thank you, everyone.
Thank you.